Good afternoon. Thank you. Thank you for the kind invitation to present here. Okay, so IVF Worldwide is the largest and most comprehensive website focused on IVF. It is addressing scientists, physicians, embryologists, nursing staff, and also a lot of patients show interest in this website, in this platform. It includes a lot of educational material. There is a lot of information, newsletters, and education center, the ability for physicians to consult each other, to interact. There's an online journal. It's the IVF Worldwide Journal, and also surveys. It is very attractive to conduct surveys through this platform because there's a large number of units that are registered from all over the world, and we can achieve data from academic and also from non-academic practices on a global scale. And this way we can get the wisdom of the crowd. So it's not from academic centers. It's why the wisdom of the crowds, why the many are smarter than the few, and how collective wisdom shapes business, economies, societies, nations, but also it is the same. It holds true also for medicine. And numerous surveys have already been conducted through IVF Worldwide. And many of them, the results of many of them were published in peer-reviewed journal. And one of the latest additions to IVF Worldwide is the Virtual Academy of Genetics, which is mainly an educational project, and it also includes information about CoGEN, the annual meeting, the PGS position statement that was released last year following the first meeting. And recently we've conducted a survey on the use of PGS worldwide. Here's an example of the educational material you can find in the website. And the purpose of the PGS survey was to evaluate the extent and the patterns of use of PGS worldwide, and to get an insight on the views and opinions of the ART community on the use of PGS. And the survey was conducted by Simon Fisher, Yuval Yaron, and myself. And we had a nice turnout of from about almost 400 units, nicely distributed around the globe. And these units represent 342,000 cycles per year. So, and as you can see, we had responses from all over the world, from all 5 continents. The first question was a screening question. Is PGS currently being used in your clinic, yes or no? And then there were 2 kinds of questionnaires, one for clinics that do PGS and the other one for clinics that do not do PGS. I will focus on the clinics that do PGS. And we had a 77% response for the question, is PGS used in your clinic? So obviously there's a huge bias here, selection or attention bias, because it caught the attentions of people who are interested in PGS that answered the survey. And the next question was, to what extent is PGS being used in your clinic? And we can see that the majority of clinics, it is less than 50%. Actually, the biggest part was 37%, less than 10% of the cycles. Very few clinics worldwide do PGS for more than 50% of the cycles. If I was looking also to see what's going on around in other databases in other parts of the world, so here's the CDC SART data from 2013. In the United States, 6% of cycles used either PGD or PGS. And if you look at the distribution of clinics in the United States, so again, you see that it is quite similar. The majority would do 10% or less, and very few clinics would do more than 50%, actually only 2%. And this is true for 2013. And there's also raw data now available for 2014. Interestingly, less clinic reported to start in 2014, and we could see that about 26% were not using PGD, PGS in 2013, and this rose to about 35% in 2014. So this is a little bit surprising because you would expect to see a rise. And same here, very few clinics in the United States are doing PGD, PGS in a big proportion of their cycles. Actually, very few do, in more than 50%. And this rate has declined from 2013 to 2014 to about just 2% of the cycles. If we look at what's going on in Europe, this is data that was presented in the last ESRA meeting. This is data from the consortium. So this is coming only from clinics that do PGD and PGS, and this is data from just 50 participating centers, and they are mainly from Europe. So you can see that after a drop in 2013, this was the death of PGS version 1. We see a gradual increase now from 2013 to 2015, about 4,000 cycles reported in 2015, and we see an increase both in the use of PGS for chromosomal abnormalities, for monogenic disease, PGD, PGS, and actual PGS. We see a steep rise in 2015. The next question was which patients are being offered to include PGS in their treatment cycle, and in this question there was only one possibility to answer. So we see an equal distribution, almost equal distribution for patients with advanced maternal age, repeated implantation failure, and recurrent abortions with normal karyotape. Very few units around the world are offering PGS to their good prognosis patients or to all the patients in their clinic. Next question was whether ovarian reserve was a major factor in the inclusion criteria of PGS in the clinic. And about 40% said yes, but only in 17% exclude completely patients with low ovarian reserve from their PGS program. Another way to look at it is to ask whether a minimum of embryos, blastocysts are necessary for inclusion irrespective of ovarian reserve. So almost half of the responding units said yes, 44%. So there's a minimum of embryos or blastocysts that are necessary to be included. Regarding funding, we see that almost all over the world, the vast majority of the patients are paying out-of-pocket money. And in very few countries and setups, PGS is covered somehow by the public or private insurance. And what kind of biopsy, what stage of biopsy is being done now? We see that the majority of biopsies are done at the blastocyst stage, trophectoderm biopsy, day 5 or day 5 and 6. A quarter are still doing blastomere biopsy. And another question was, do you perform PGS on frozen thawed embryos if the patient fails a non-PGS cycle? So 70%, that's interesting, 70% of the respondents said yes. And which method of genetic testing is predominantly used in your clinic for determination of embryo ploidy? So we see that FISH is still used in about 10% of units. The majority are using array CGH, and we see that there's probably an increasing number of units that are using NGS. And if we look at what's going on in Europe, we could see that Europe has switched from cleavage stage to blastocyst stage and from FISH to array CGH, and there's no information in this database that was presented in the last ESHRE meeting on NGS. And the majority of clinics are using a centralized referral laboratory. Relatively few are doing, a quarter are doing in-house genetic laboratory. And which method of transfer is preferred in your clinic? I would say that the majority are using either frozen thawed embryo transfer or both. And 22% only opt for direct fresh transfer. How many euploid embryos do you normally transfer? Single embryo transfer as a policy is practiced in a third of the responding clinics. And other combinations that's selective according to the history and the clinical setup, or based on patients' request, we see in different clinics. And the next question was, do you think that PGS is evidence-based? So only 30% of the respondents agreed that PGS is clearly evidence-based. 37% would say that it is most likely evidence-based. And there was almost a very impressive agreement, 84%, that more randomized trials are needed to support the use of PGS. And I will also show two slides from the part that said that no, we're not using PGS. So that the second part of the questionnaire, why is PGS not performed in your clinic? So most of the majority was either lack of skill or funds or staff and instrumentation, lack of demand by patients, including financial considerations, so a lot of technical and cost consideration. And in almost a quarter of the responding countries, PGS is illegal. And 18% other. That means perhaps they don't believe in PGS. But the majority said that it is clinically justified to offer PGS. That means if they had the possibility to offer it, they would offer it. So the conclusions of the survey were that the results clearly emphasize an increasing role for PGS in current practice. We see a steep decline in the use of FISH, with an upturn in area CGH and a recent rise in the use of NGS. We see a decline in cleavage stage biopsy in favor of blastocyst stage biopsy, and there is a clear demand for well-powered RCTs. And the results also support the position statement on PGS that was issued in the first CoGEN meeting in Paris last year. And talking about surveys and talking about mosaicism that's been heavily discussed today, we would like to offer the next survey. I will just show you briefly some questions that will be included and feel welcome to add, to suggest, to modify some of the question. As you know, mosaicism is a challenge for us, and it is also a major source for criticism that the PGS is receiving. So we would like to ask about the platform that is being used for CCS. What is the optimal number of cells that we aim to achieve in the biopsy? Again, if the genetic analysis is performed in-house or a centralized laboratory, would you like to receive, do you receive information on mosaicism from your laboratory? What is the percentage of mosaic embryos that you see in your practice? Many of these points were already mentioned today. What is the percent cutoff for a mosaic embryo to be considered abnormal? Do you ever rebiopsy mosaic embryos? Should mosaic embryos be kept or discarded? What is your advice to patients with mosaic embryos? Do you ever transfer mosaic embryos? What kind of mosaic embryos would you consider transfer? Monozymic, trisomic, which kind of trisomies would you consider transferring? And how would you follow a pregnancy, follow transfer of mosaic embryos? And the last thing that I would like to present and to suggest is a new platform that we would like to bring up in IVF worldwide is in what we call an RCT centers. As you know, and we see and we hear all the time that we lack Class A data, and we're missing a high quality and well-powered randomized controlled trial. And since there's over 3,800 clinics that are registered in IVF worldwide from all over the world, and since we are getting data from both academic and non-academic clinics, we would like to create an RCT platform where we, or you, of course we would take suggestion, provide the platform, provide the topic of interest for the study, for the RCT, and we can provide the scientific background, the patient information and consent forms, the basic needs for ethics approval submission, everything that you need in order to start a study, even if you're not very academic and even if you are not experienced in conducting RCTs. We have a good likelihood of getting high quality data that can be well powered at a very relatively short period of time with the decreased levels of heterogeneity if we all stick to the same protocol, and it could be a new source for high quality data, and it could be a good and significant contribution to evidence-based medicine. So you are welcome to suggest new topics for surveys and also practical and relevant topics for RCTs. Of course, this should be simple and not studies that require a big funding. So here's my email, and I thank you for your attention.